A very pleasant good afternoon to all of our viewers. We want to take the opportunity to welcome you to another edition of Let's Talk. We are in fact delighted that you have chosen to join us this afternoon for our continuing discussion on this very important subject of cancer. We are discussing the subject of cancer and the Christian. Last week, we started our discussion and we are continuing this discussion. Before we go any further, we would like to invite you just to have a word of prayer with us at this time. Shall we bow our heads as we pray? Almighty Father and our God, we thank you for the opportunity to minister to our friends in Radio Land. We thank you for the opportunity to come by week after week and speak via the internet and the Second Advent Radio. We pray that, especially as we discuss this very important subject, that you will be with us and that you will guide in our deliberations. In Jesus' name, amen.
Yeah.
I want to welcome us all again. I am, like last week, I'm seeing something indicating that we are not live. I am going to double check that in a moment. Just one moment. A pleasant good afternoon again, and sorry for the slight interruption there. I was getting a false signal indicating that we were not live, but I see that that was a false signal.
Slight interruption there. I was getting a false signal indicating that.
We do apologize for that, and we trust that our viewers are seeing us and that those on Second Advent are also hearing us. I want to just welcome us back to Let's Talk, and I trust that all is well. We are talking this afternoon, continuing our discussions from last week with Dr. Natalie Greaves. She is a lecturer at the University of the West Indies. She is a cancer researcher. She has a PhD in palliative care, and she has been involved in so many areas with respect to cancer research. We started a very important discussion last week, and we're going to continue that discussion now. Dr. Greaves, welcome to Let's Talk. It's a delight to have you with us one more time.
Thank you, Dr. Greene, for the invitation and the opportunity to share.
Wonderful. Now, last week when we ended the discussion, I started asking a question that I did not have time to follow through on, and it had to do with the explanation, not really a question so much, but an explanation of some terminologies. You know, an individual may have a lump in the breast or somewhere else, and the doctor does a biopsy and reports that it is benign. We sometimes assume that everybody knows or understands the terms we use. I do not want to take anything for granted. We have a wide range of those who listen to us. So I'm going to ask you to explain a few terms. I'm going to ask you to explain terms like tumor and benign and malignancy and metastasis. Let's biopsy. Let's stay there for now, and then we can take some more. So can you take us through tumor? When we say tumor, when we say something is benign, when we say something is malignant, what are we talking about?
Okay, so firstly, I want to thank you for the opportunity to answer this kind of question. Hello to everybody. Good afternoon. I'm hoping that you can quickly go and get a piece of paper and a pen or a pencil and just take a few notes because what we're talking about is health literacy, which is really around the ability of a person to gather the information that they need, understand the information, and then use that information to make health decisions. So the whole language of medicine is not necessarily what people talk about or speak every day. So it's good for persons to have opportunity to be educated on the language of medicine. And I would want everybody to know that there is an American institute. So I have a little bit of a tickle in my throat because of something that was sprayed recently. So forgive the clearing that you will hear occasionally. So there's an institute called the National Cancer Institute. It's part of the National Institutes of Health in the US system. And they actually have an online cancer dictionary that I think will be incredibly useful. So I'll probably share the link for that or the URL for that later. But when you go to that dictionary, you can actually find most of the definitions of the terms that persons will commonly use, doctors we might use, taking for granted that people, are understanding. So when we think of a tumor is essentially a growth or a mass. So remember last week we talked about the fact that we're made up of all of these cells. And if a cell is growing more than it should and it's dividing more than it should, and it creates a mass, that mass is also called a tumor. Now, there's another word that we can use for it. So sometimes you might hear people say neoplasm, which is like a very fancy word for saying a new growth. But a tumor is a mass, a collection of cells that have grown more than they should. It seems like because of my internet, the image might be changing a bit, but I hope that everybody can still see because of the bandwidth. So that is what I would want persons to understand, that if you have a mass or a growth that is occurring because cells are dividing more than they should, that's what we mean when we say a tumor. Now, a tumor can be benign, which means that it's not cancerous. Okay, so it's not, the cells are growing and they're dividing more than they should, but they're not in the category of being a cancer. But there are also some tumors that are malignant, meaning that they are cancerous growths. So a cancerous growth is called a malignant growth. And usually one of the things that helps us to understand whether a tumor is, when I say a tumor, a growth is cancerous or not, is the ability of that tumor to spread to other organs. Yes, how it looks under the microscope, if it looks like it has the capacity to spread to other organs. And the process of spreading or invading other things is called, especially things that are far away, it's called metastases. So say, for example, if I had a tumor that was a mass in my abnormal growth in my breast, and it showed signs under the microscope that it was of a cancerous nature, and it got away from where it was in my breast and spread through my bloodstream or my lymphatic system, which is another set of channels in the blood, in the body, to another part of my body, say for example my tummy, that tumor cell in my tummy would look like where it came from, and that process of spreading is called metastases. So I'm hopeful that that helps.
So again, some people use the term devil's advocate. Just to
No, you're just probing.
Yeah, I want to make sure that everyone is following quite clearly. So some tumors are benign and some are malignant.
Yeah.
Now, can a benign tumor become malignant?
Yeah. It can. We can say that it can undergo malignant transformation. So some benign tumors can undergo a change in behavior and become malignant, but many others just stay benign. So I want to go back to what you said about biopsy. I just want to make sure that people understand that. So what helps you to understand the risk of something moving from being benign to malignant? One of the things that can help to understand exactly what's going on with the cell is the examination of those cells under a microscope, or if they undergo particular tests. And in order to get a sample, you have to do something called a biopsy. So say, for example, I'm going to say I'm at church potluck or something like that, and they have desserts and they have different cakes. And somebody said, this is banana bread, and this is this and this. and I might say, can I have a sample to see exactly what it is like? So that is the process, so that you can take a sample in different ways. Sometimes the doctor may take just a small incision, make a small incision and take out a piece. So that's like if you're gonna take if you're gonna take a piece of the cupcake and sample it that way, or the doctors may say, hang on a minute, let's just take this whole cupcake out and examine it and figure out exactly what it is, and that's called excisional, where you take the whole thing out. Or we have these people like surgeons that especially are that do these, or gynecologists that do the sampling. They're the ones that usually do the sampling. They may have a needle, small needles that they can insert into the tissue, or into, in this case, the cake, and take out a small sample. If they use a fine needle, that's called a fine needle biopsy. If they use a slightly larger needle where they can get a good set of cells and tissue, that's called a core needle biopsy. So there are different types of ways of obtaining samples. And then when you take the sample is then usually sent to a lab where there's another kind of doctor called a pathologist that looks underneath the microscope to look at the cells, to look at how they're behaving, to see whether they are benign, meaning non-cancerous, or if they are cancerous, or if they are benign, if they look like they have they want to become cancerous. So that's why you might hear a doctor saying, we think that this is what is going on with you, and the next step is to take a biopsy. And so when we say biopsy, we're really just meaning sample, and then the examination of it.
Okay.
And then you'll get the biopsy results. Right?
I get you. Wonderful.
Okay.
So an individual who feels a lump doesn't need to immediately become petrified, mortified, rather, because, oh, it's the end of the world, I have cancer. Let's check it out. Let the doctors do a biopsy if necessary, and wait until the results come before you begin to worry.
Absolutely.
Yeah.
Absolutely. And I think that leads us into the process of achieving something called a diagnosis. So when we say a diagnosis, it is almost like an understanding of what exactly is going on. So say, for example, you have fever, headache. I'm not talking about cancer now. So if you have fever, headache, behind your eyes are hurting you, etc., and it's, rainy season in the Caribbean, you might start to think, oh, maybe I have CHIKV, or maybe I have Zika, or maybe I have dengue. But you will go to the doctor will listen to you, they will think about your symptoms, what you're feeling, they will examine you, they may order a couple tests, and then they will come up with the answer of what you're going through. It's the same thing with cancer. So you may have, in this case, we're talking about a person with a lump. Person may have a lump, and they will go to the doctor, they will give the history, how long they had the lump, if the lump hurts, when did it come up, if it was ever bleeding, if it's growing quickly, different kinds of things the doctor will ask. And then the doctor will examine, they will say, well, is this lump very hard? Is this lump hard but still soft? Does it feel craggy like a rock? Is it fixed to the skin? Is it attached onto the muscle? They'll start to think about it, and then they may facilitate the person in getting a biopsy or some other kind of investigation, and then you'll be able to come up with an answer, which is kind of like the diagnosis.
Okay, wonderful. Now I want to ask you to explain a few more terms, so that in our continuing discussions, when you use these terms, that our listeners can be aware, or even not here, they go to the doctor or they're talking to somebody and a term is used. So we have a few more terms that I think are important to our cancer discussion. Carcinoma, sarcoma, carcinogen. Now you mentioned diagnosis already, prognosis, that's for any general, medical terminology. And then after you do all of that, we'll come back and talk about chemotherapy versus radiotherapy.
Okay, so I'm gonna need you to help me to stay on track with these ones, okay?
No problem.
So we'll talk about the carcinoma and the sarcoma ones, okay?
Yes.
So everybody listening out there, don't become intimidated or anything. As I said before, there's a language that we use as physicians when we're talking to each other, and also that we want our patients to understand. So usually the carcinoma, sarcoma helps you to understand where in the body, what kind of cell type it is. So when you're talking about a carcinoma, you're usually talking about a cell that is like a skin cell or a surface cell that is usually lining an organ. So say, for example, if I have something in my colon, and it's coming from one of the glands that is lining the colon, it might be a adenocarcinoma, a glandular type cell. So that's like a descriptive term. So when you're talking about a tumor that is coming out from a cell lining, a cancerous tumor that is coming out from a cell lining, you're usually talking about a carcinoma. How should I put this? For those ladies out there who make beds, I'm talking about maybe a cell that would be like a fitted sheet or a covering sheet, as opposed to a cancer that's coming from the mattress. So if it's something that's lining or on one of those top layers, that's the easiest way I can think about. You might call that a carcinoma. Now, sarcomas, how our bodies are made up. We have all of these connective tissues. We have these tissues that perform different things and they're supportive. So we have muscle tissue, we have bones, we have blood vessels, we have lymphatic system. So if a cell is coming from like the bones or the muscle, etc., or the blood vessels, etc., then that will be what we will call a sarcoma type tumor. So and then you put on the Latin for, and I'm smiling because I remember my days sitting down at Mona stressing over these words. So if you have a bone tumor, you might say osteosarcoma. If it's coming from the blood, you might say angiosarcoma. If it's coming from the muscle, you might say rhabdomyosarcoma. So those are kind of like codes that help us to know which part of the body, what kind of cell is really being affected. And that's how I think is a good way to understand it.
Okay, wonderful.
And there were some other things that we needed to answer.
Yeah, we used the term quite a lot last week, carcinogen.
Right.
That something is carcinogenic.
Yeah.
Again, assuming that everybody understands. So again,
Sure.
Yeah,
So a carcinogen is any substance, and as it relates to sleep, especially people who work shift work, that's where the bulk of the evidence is any substance. And in this particular thing, the probable carcinogen of sleep in shift work that's the pattern of the lifestyle. But it's any substance that has the ability to cause a change in a cell and give rise to a cancer. Yeah, so that's what a carcinogen is. Yeah.
Okay, wonderful.
Yep.
Now, just a couple more terms.
Sure.
Well, I think I did have another one. You referred to diagnosis,
Yeah.
letting the individual know exactly what is their condition, what is the results of the investigation. So what about prognosis?
Right. Okay, so prognosis is totally different from diagnosis. Diagnosis is almost like the answer to the question about what is going on with you. But prognosis relates to the course. The likely is not guarantee. It's the likely course or the likely outcome of an illness. So for example, some persons may be diagnosed with a particular illness and they may want to know, doc, nurse, how will I do? How will this turn out for me? So how things are likely to go is called the prognosis. How things are, the course that the person is likely to go through. And sometimes people can equate that to how long a person will survive and what are some of the things that might happen to them. So that's really what a prognosis is about. It's really about the likelihood or the course that the disease could take. Let's say that.
Okay, great.
It's not a guarantee. Okay, because I know that, remember last week you asked me about some people that go to the doctor and they get a diagnosis and they hear X or Y and then they come back and then they're really, really sad and they get depressed and stuff like that. So I just want us to know that it is based on an overarching picture of science and it's a likely outcome. It's not an absolute guarantee.
Yeah, so it's a sort of predictor.
That's a good word. Yeah,
yes.
based on the best available evidence.
Mhm. And finally, in terms of terminology now, we refer to treatment. We are not necessarily discussing treatment in any great measure right now, but we refer to treatment and we speak about chemotherapy and we also speak about radiotherapy. What is the difference between chemotherapy versus radiotherapy?
Okay, sure. So when we think about chemotherapy, we want to think about the medicines, or some people might say the word drugs, that are used to treat a cancer. Okay, so the medicines or drugs that are used to treat a cancer. And those can be given tablet form. They can be given infusion or some through your bloodstream, etc. So when we're talking about chemotherapy, we're usually talking about medicines to the extent where there's a branch of cancer specialists called medical oncologists, and they usually work very closely in terms of understanding medicines and which medicine to use when, in which order, and working out how much a person is supposed to get. Because Dr. Greene, you're a male, you're a particular age group, you might have different conditions in your history, etc. If we both had the same type of cancer, your medicines might be different from my medicines. The amount that I get, the order in which I get them might be different. And so therefore chemotherapy is the medicines that are used to treat cancer. Now, as a person who believes in a creator who made heaven and earth, we have energy in this universe that is created. A lot of our energy comes from the sun, and the way how energy moves, you have different kinds of rays. So radiation is treatment for cancer that uses energy. Yes, so there are different kinds of energy particles that can be used. So depending on the speed of the energy wave, so there may be X-rays that might be used to treat, and then there are certain kinds of treatments that may use different parts of the atom. For those of you who like chemistry and so forth, so God has made these. We are all made up of atoms, and atoms can move, and they have neutrons, and they have electrons, and they have protons, and it's harnessing that energy that God has put in the universe. That's how I'm putting it, to treat cancers, and that's what radiation is. And radiation can be given from the outside, so you lie on a machine, or lie on a flat surface, etc., and the radiation is projected onto you to the particular part that needs to be treated. Sometimes there are little beads that can be inserted into certain organs that will give off the energy that is needed to destroy those cells. And in really advanced cancer treatments, there are some types of radiation that can even go through your bloodstream now and be very specific. So chemotherapy, to revise, is the medicines that are used, and the radiation is about harnessing energy, different types of energy, to specifically target cells that are behaving bad and cause them to be destroyed. I hope that helps.
Oh, certainly. Last week, somebody mentioned to me, they said, oh, she explains things so simple. You can, even a child can understand. So you're doing an excellent job. Well, let's move on now. I believe that by now, it's common news that the King of England, or should I say the UK, the United Kingdom, has cancer. That announcement was made during the course of the week. It just shows that cancer is no respecter of persons. So I want to follow up on something you said last week in response to my question about the popular types of cancer. One listener was a bit surprised that you did mention that lung cancer, I think they said, was not so prevalent because smoking was not a big thing. The listener commented that smoking may not be a problem in your country, but that in his country, smoking is definitely a problem. And so you probably need to say something about the dangers of smoking and lung cancer. Can you share on incidences of lung cancer, maybe around the Caribbean, and the relationship between that and smoking?
Yeah, so tobacco smoking is a huge risk factor for lung cancer. And when we look at Latin America and the Caribbean as a whole, we see the pattern that countries where tobacco smoking is very prevalent, etc., they still have higher numbers of new cases of lung cancer. So I think we should say that you had told me before, because I wanted to know if I should answer the person during the week. So I know which country this person is from. And so their country, which is Trinidad, they have a higher rate of smoking than many other English-speaking Caribbean countries. And when you look at the lung cancer rates, you will see that pattern being higher than other islands. So for them, prostate cancer, and then they will have lung cancer featuring, and then they would have colorectal cancer featuring in their men. You will also see a similar pattern in like Cuba as well. So there is an important relationship between use of tobacco and the incidence of lung cancer. As a whole, Latin America and the Caribbean, especially when you drill down into the data, you will see that as compared to parts of Central and South America, the English-speaking Caribbean islands where smoking tobacco consumption is relatively low, because we have adopted some parts of a framework, a public health framework that helps to control tobacco in some of these countries. And generally tobacco smoking is not a strong cultural practice. But should we move in that direction, we would start to see those changes, because we do know that there's a proven link between tobacco smoking and lung cancer. So I have the advantage of knowing that that person is from Trinidad, and that is what they're seeing there. Yeah, for sure.
Okay, wonderful, great.
Yeah.
So there is definitely that relationship. So
We've
while we
known it
talk
for
about
many years now. Yeah.
okay, yeah, and I can't help saying this, but sometimes you wonder, because the tobacco industry, is a really big industry, and I do agree that we have made some strides in educating people against the dangers of these things. But you wonder, when there is such a clear, strong link between something that is so very carcinogenic, why is it still legal? That's just a question, I wonder.
I don't know that I have the answer for that question, but I think that we live in a universe where people have choice, and we educate persons, and we give them the best information to make the most informed choice. And I think that that's probably what we're seeing working out. But some of the measures that have been put in place with this framework for tobacco control, it says like tobacco should not be sold to minors, because we don't want children starting to use tobacco at young ages. The length of time that you use the tobacco, the amount of tobacco that you use, etc., is going to have an impact. So we certainly don't want tobacco to be available to children. We don't want it to be affordable, like very affordable. So we don't want it to be sold in units where I have a little piece of string here on my desk, where a person could go buy a small amount, because that is going to be useful. So you don't want to sell it in singles, in terms of cigarettes in singles, etc. You want to maybe have systems in place in your country where if people have to buy it, it has a tax on it that makes them think about whether they really want to spend their money that way. And then we want to I have all kinds of crazy stuff on my desk, but this is called a desktop humidifier. It keeps the air clean. But if you have a tobacco box, you want to make sure that people know that the Ministry of Health or whatever says that this thing is hurtful and harmful. And in some countries, they even have permission to put graphic warnings, like examples of what could happen to your body on tobacco. So I think it's kind of like a balance between economics, choice, and people being informed to make the right decisions.
Okay, wonderful. Now, while we are on the subject of smoking, Some Caribbean countries are making it easier for persons to use marijuana. I know that is not tobacco. Since it has been decriminalized, it appears that the average young person, at least it appears so to me, I see so many persons smoking these days, right? And I'm not talking about tobacco, no, I'm talking about marijuana. The average young person on the street corner is smoking. Are there carcinogenic substances in marijuana smoke? Is it related to cancer in any way?
Dr. Greene, you come up with the hardest questions. So I'm going to take this in two components. I think the conversation about marijuana and carcinogen is a bit of something that is not fully explored yet, and I'm still personally on the fence with the evidence, erring on the side of pure marijuana leaf as used does not appear to be. There's not a strong evidence base linking it to lung disease, and in particular lung cancer, and being a general carcinogen like how tobacco is. What I would say is that what is legal in many countries, the difference between recreational and medical use. So I think recreational use of marijuana has some potential things that we need to really consider from a public health perspective, because we have to have respect for herbs and what they can do. They can not only do positive things, but they can also have negative repercussions. And what is perhaps more known related to marijuana might be the effect that marijuana has on the brain, on the developing brain of the young male, and the likelihood of them having disturbances in behavior, disturbances in their thinking and their thoughts about what is real and what is not when they use marijuana. So my concern is the evidence base that we have in the Caribbean about the association between marijuana and some of the mental health impacts on young people, especially young men. So I think that is an important conversation to have, even as we go through the legalization process. What I would say is that also, I've never used marijuana, I'm just saying that out front, but I know in our culture, we tend to mix it with other things as well. And sometimes people are buying things and they know not what it has been mixed with. And that also worsens the mental health impact. And I know you didn't ask me about this, but marijuana has some components of it, in particular, some things called cannabinoids that when extracted and used in appropriate doses by trained persons, that can help with things like pain and nausea and fatigue, etc., in select patients. So I would say that just as how, there are some plants that we use wisely with appropriate training, that there's a role for, I'm not sure if you're going to have me back on your show after this, but there's appropriate use of medicinal cannabis. There are certain components are in particular ratios, and you are certain of what you're having, and it's prescribed by an appropriately trained person. So I'm going to just take one more minute. So say, for example, medicinal cannabis has the ability to affect something called the sodium gated channels on the heart. So personally, if I have a patient and I'm prescribing medicinal cannabis, because I do prescribe it, I'm not going to prescribe it to a hypertensive who has heart failure and is on a medication that we use to control the amount of fluid that is building up in their body, because I know that that could cause them harm. So that's why I say that we have to have respect for the plants that God has given us and the components of those plants that need to be used. Well, I hope, Dr. Greene, that you will have me back.
This is a good place to follow up, right? Because not the statement you just made, that we have to have respect for the value in the plants that God has made. I believe that every plant serves a purpose, and I think one of the arguments that people like Rastafarians were making with marijuana is that why are you going to jail me for growing a natural substance, a substance that occurs naturally? But here's my question. I don't think anybody doubts that there are positive substances in these plants, and there's a lot, I've heard a lot about many of the things and so on. Our health food store sells hemp seeds. But my question is, whether it be marijuana, whether it be tobacco, whether it be cocoa, whether it be, let's say, sage that we use to make tea and to season things, etc. There's one thing with making some tea. There's another thing with wrapping it in a paper and smoking it. What I'm asking is the process of burning the substance, does that add danger to it? If I take soursop leaves, there is this view that soursop is a good cancer treatment. But if I burn it and smoke it, would I still get the same benefit?
Okay, so I just want to make sure that I am very clear before I get into anything related to graviola. However, how you deliver something to your system is going to have an impact on how much damage it can cause. So you're spot on there. Why I'm saying that I'm on the fence is because there still needs to be a lot of work done on how smoked marijuana impacts the lungs. So we already have established what happens with tobacco, but there is a body of evidence that is growing that says frequent use of smoked marijuana can very well have a negative impact on the body, okay? In terms of a particular kind of cancer that affects the testicles in men. But it's so new, I don't want to put it out there to say, for people to say, oh, the doctor get on the thing and say that you'd smoke the weed and it's going to cause testicular cancer. You see what I mean? So, but I think when the more important issue with this marijuana is what it's doing to the minds of people. So I agree with you 100%. That's why we have a lot of indigenous knowledge in the region. So everybody know you don't chew a whole nutmeg. You don't, because it's a Carson is a cyano agent. It can damage the liver. So our grandparents told us to grate a little bit of nutmeg. That's all you need, and steep it in the water and drink. So how you prepare it, how you consume it is going to have an impact. And just to say that a lot of plants around us are used as chemotherapies, as medicines. So the periwinkle flower, the little purple periwinkle flower that we have in the Caribbean, that's used to make a drug called vinblastine that's used to make to treat tumors in the brain. There's a tree called the Pacific yew tree. The bark of that tree is used to create some medicines called taxanes, and those are the mainstay of breast cancer treatments. So yeah, the power in the plants is being analyzed and being brought to life, but sometimes we might not recognize it. Yeah.
Maybe it's a good place to ask this question from one of our viewers. I know we are going to talk about treatment options in another program, but I'll go ahead and ask it anyhow, since you mentioned that. And the question is, why are conventional physicians so reluctant? And even I'm reading the question that the viewer just posted. Why are conventional physicians so reluctant and even antagonistic to acknowledge alternative sources and procedures that have had great success in preventing and curing cancer? That's the question from the listener.
So the question seems to have two parts. So it's saying, why are allopathic physicians so antagonistic or seem to be resistant to successes brought from other forms of treatment?
Treatment options.
I can't see. So that's how I'm going to answer. I think the relationship, I can speak from personal experience on what the science would suggest. The relationship between the two branches or the multiple branches of ways of treating, the relationships have not always been as strong as they could be. And I think that the antagonism that may be perceived is because of lack of communication, one, lack of a shared understanding of the body and how it works, and two, some people may benefit from vilifying the other person. So don't go to the regular doctor. They're only interested in money. Don't go to the other practitioner. They don't know what they're doing, as opposed to having meaningful conversations and dialogue. And there's a branch of science now, medicine. I am an allopathic physician, which is a fancy word for saying the way how I was taught medicine is that we see the body as functioning in a particular way, and we try to do the reverse to help the person to feel better. Okay, so that's how modern medicine tends to work. And it says I have to talk to you, I have to examine you, I have to look at particular investigations to figure out what I'm doing, and I'm obligated to never do you any harm. I'm only supposed to do you good, and I'm supposed to have justice across all my clients. I'm supposed to take time, I'm supposed to talk to you, I'm supposed to empathize. And that's what a regular doctor is supposed to do. But I'm also supposed to respect your choice. I think sometimes we have a challenge when we see people making a choice that we don't necessarily agree with, especially if that choice is because they're talking to some other kind of practitioner, and maybe that's where the antagonism comes. Personally, I feel very hurt, almost to the point of crying, if I know that a person has a cancer and we want to try to do something and they opt to do something that I know that other people have tried, and I've looked at it and I've researched it, etc. And I can just see them deteriorating even as they're trying something that I can see that is harming them. But you have to respect the person's choice. So the other thing that I think in our region, why there might be the antagonism, is because a lot of the practitioners who might not be standard medical doctors are not regulated. So sometimes we may see our patients going to somebody, but we don't know their training. They might not want to talk to us and tell us how they're trained or why they're trained or their background knowledge from their grandparents or whatever that they're using. And the dialogue breaks down. So I think a lot of it is communication sometimes, and then just fear and concern for your patients. But there is integrative medicine now, and there's a holistic approach to cancer care. So for example, in Barbados, where I'm based, for a long time, we've had a medical herbal practitioner that we tap into. She's appropriately, she's trained, and from University of Wales in Cardiff, a sound, solid program. She looks at the lab results, is able to offer what she wants to offer if the patient doesn't want to take the traditional medicines that we would want to. But there is dialogue, there is communication, and so forth. I think a lot of the antagonism comes when people aren't talking to each other and there's no respect.
I do agree with you 100%. You know, and especially in the area where you spoke about one person trying to make the other person look bad, and you know, or they're only after your money, or they don't know what they're doing, so don't bother with them. But the dialogue is so very important. And but we're going to talk about that some more sometime else. You know, my intentions today were to really. I'm saying that because I'm looking up at the time and I'm realizing we only have about 12 more minutes. And my intentions today were really for us to talk about colorectal cancer.
Okay.
But time has gone.
We can still do it. You'll be amazed at what we can cover.
Okay, well, I'm going to trust you with that one.
Yeah, man, we can do it.
Yeah. So let's begin by asking, what exactly is colorectal cancer?
Okay. So I'm just going to paint a picture. So you had lunch today, I hope, Dr. Greene.
Yes.
Everybody else had lunch. Okay, so how we are made, we have a system called the digestive system. And the digestive system, so when I eat a piece of bread, I have to chew it. Some enzymes are released in my mouth. I have to swallow it. It goes down my throat, and then it goes down my swallow pipe, which is called the esophagus. This is the normal anatomy. And then it goes into my stomach, where it gets churned up and digested some more, and then it goes into my small intestines. In many Caribbean islands, we talk about tripe, right? So it goes into my tripe, and it goes into my small intestines, where it's broken down more and good nutrients are absorbed from it. And then after that, it goes into the colon. Yeah, so the colon is called the large intestines. So it's wider than the small intestines. And the purpose of the colon is really to absorb extra water so that we're not wasting water, because we're pretty much between 60 to 80% water, our body. So we want to suck out all the water that we can out of any food that we have. So the colon is to make sure that all the water is absorbed. And how the colon is made, I wish I could draw, but you just follow me. On the right side of your body, just down, just close to your hip, that's where the appendix is, and then it leads into the colon, the right side of the colon, and then it goes up to where your liver is, then it comes across the middle of your abdomen, the belly part, and then it comes down and then out to the bottom, yeah, the anus. So the colon, the function of the colon is to suck out all the water out of the digested matter, and what you're left with is waste. So the colon is to push the waste out so it doesn't stay in your body and we pass it out as feces. I just got an alert on my computer. If you don't mind, I just need 1 second to just move away from the computer just a minute and
Sure.
fix an error. Just 1 second. Shan't be long.
No problem at all. We will be right back. Those of you who are with us, we are talking with Dr. Natalie Greaves. She is a cancer researcher, a lecturer in the public health department at the University of the West Indies Cave Hill campus. And she has been doing a phenomenal job in guiding us with some information related to cancer. She's currently responding to what is colorectal cancer.
Right. So in what we covered before is that the last part of the digestive system is this system of very structured loops that sucks out the water and produces waste that is then excreted when we defecate. That's the natural system. So it has a right side, it has a lateral side, which we call the transverse, and then it goes down. Now, what happens with colorectal cancer, it says that something is happening in that system all the way down to the rectal area. The rectal area is the very last bit of the colon before the stool comes out. And something changes on one of those cells in there and causes the cells to grow more than it should. And it changes so that it's no longer, these are words that we established before, it's not a benign mass, it's a cancerous mass. And that is essentially what happens in the colon. So I can cover very quickly some of the things that causes the cells, that increases the likelihood of the cells in that area to become abnormal. So we talked about tobacco smoking before. We talked about last week we mentioned alcohol, but alcohol can have an impact. If you are sedentary, if you sit a lot and you're not exercising a lot, that can increase your risk. If you have, so that's not a good structure that I'm using. I should say there are things that are modifiable and things that are non-modifiable. In other words, things that you can change and things that you can't change, okay? So we'll talk about some of the things that you can change. A lot of what you can do to affect your cells becoming bad behaved relate to diet and lifestyle. So alcohol, tobacco, being sedentary, like not exercising, using food that is low in fiber. Yes, so high fiber foods help the stool to move through faster. So those are very important. But what we don't want to eat, we don't want to eat a lot of red meats. One, we don't want to eat a lot of red meats that have been charcoal grilled, because when they're charcoal grilled and they have the blood in them, so if you're barbecuing and it's on charcoals and it has the blood in it and we like it nice and brown, that changes the structure of the blood in the meat, and then when it gets down into the colon, it can damage the colon. And we also don't want to eat things that contain a preservative called nitrates. So a lot of the processed red meats, because we want them to stay on the shelf long and to last long, they will have in that. So like pepperoni and certain kinds of corned beef and spam and those kind of things, you don't really want to use those, yeah. But then they're non-modifiable. So there are some things that people cannot change, right, because of their genetics. So we do know that there's some families that have certain genes and certain conditions where they may, from very young ages, start to have growths in their colon, or they may have changes that can occur because of the genes that they have. And then there's some persons who may have like chronic inflammatory conditions, like where their colon has a lot more inflammation than normal persons. So persons with like Crohn's disease, which is a disease where you have inflammation in your bowel, or ulcerative colitis, those kinds of things. But what we also know is we believe it's kind of modifiable-ish. So some persons with type 2 diabetes, depending on how many risk factors they have in addition to type 2 diabetes, it carries up their risk of having colorectal cancer. But the good thing about colorectal tumors is that you can pick them up. You can pick them up very, very quickly. If you are able to get on a schedule where you can be checked often, or checked at a certain frequency. So if you are of African descent, like how I'm of African descent, or if you have persons in your family who have had colorectal cancer before, you may need to, like, especially if it's your mother, your brother, your sister, etc., you may need to start earlier than the normal person. The evidence has recently changed to say that if you are of African descent, you really want to be starting your screening, which is the ability to pick up if something is going wrong, around 45, okay, 45 years old. And one of the, how we can tell that something is going on in the colon, because if there's a growth on the inside and stool brushes past the growth, it may leak a little bit of blood, and you can detect even small amounts of blood in stool, yeah? So there's a sample that can be taken and sent to the lab of your stool, and it can pick up if blood is in there. It can also pick up, there are new tests that can pick up if cancer DNA cells are in the stool. It's really fascinating that we can do these things. And there's some tests that can also pick up if certain enzymes are in the stool that shouldn't be. So you can do a stool test. Now, especially those stool tests can be done every 1 to 2 years to check the stool to make sure that there's no blood coming out in the stool. There are also tests that can be done where you can take a very flexible tube. I happen to have this lacing on my desk. It's larger than this very flexible tube that you're gonna be put to sleep, put to rest and relax. Not everybody falls asleep. I admit to having had my colonoscopy already, and I was out like a light. So they pass a flexible tube into the bottom, and they can go all the way across the left side, the transverse side, all the way to the right, and do a full check that everything is going right. If they see that there's any polyps or any growths that look abnormal, you can take them out at the same time and send them to the lab for testing. And there's also other tests that can be used called sigmoidoscopy. It doesn't go as far as the colonoscopy, but it can cover some left-sided things. And in some islands, I know we don't necessarily have the doctors that can do the colonoscopies, and we don't necessarily have the newer agents for the stool tests, but we can do still things called barium enemas, although it's like a different kind of x-ray that can look at how the colon looks. But I would encourage anyone listening to us in the next 3 or so minutes that the colon is the last part of the digestive system, colorectal area. One of the main things that can happen is that it's responsible for absorbing water and creating stool. And therefore, some of the things that can happen to tell you early when something is happening is if you have blood in the stool, okay? If you are, you can have various tests that can be done, but certainly by age 45, most people should be able to have those tests. If you are consuming alcohol, consuming tobacco, not using a lot of fiber, not exercising, etc., we want you to adopt a healthy lifestyle. And if you have any inflammatory conditions, or if you have people in your family have passed away from colorectal cancer, we want you to have a conversation with your doctor faster. And the other thing that I would say in the final minutes is that, yes, blood in the stool can be microscopic where you can't see it, but certainly if you are wiping your bottom after you defecate and you're seeing blood, you're either seeing blood on the stool, in the stool, or on the paper, you can get it checked. It doesn't have to be colorectal cancer. It could be other things like diverticular disease, which is like an outpouching, or it could be hemorrhoids. But what we're saying is get it checked. And certainly if you are a man, yes, and you have iron deficiency anemia, we want you to definitely get that checked, okay? Because a man should not be anemic. Something is usually wrong. It doesn't mean cancer, but it means something that needs to be investigated. So any man that is having those kinds of symptoms should get checked. Now, if the tumor is very, very low, like down to the absolute bottom, like where it's in the rectum area, some people may have a pain when they're sitting, or they may feel a pressure or a heaviness when they're sitting, or when they're white. In the Caribbean, we would say they might see coal, right? In, you know, mucus. They might see mucus when they're white. And if that is happening, we also want you to get checked. And I think, Dr. Greene, that I have to hand over to you right now. But that is
Well,
the main information.
I was just gonna say that's a lot of information to digest.
I know, right?
Yeah,
People
so
have to take over.
I think we may have to review some of this next week because there are quite a few questions I would want to ask in response to some of the things you mentioned. But just in summing up, you are saying, it seems to me, that for males in particular, and you know, so I'm gonna ask, how frequent is this colorectal cancer? Is it something that is more prominent in males as opposed to females, or vice versa? And are you saying, additionally, we're going to steal an extra minute, that as a part of one's regular checkup, especially when they reach age 45 and over, there should be either a stool test or well, either or maybe both, I don't know. If it is required of when I go to a doctor, I'm asking, and I say I want my regular annual checkup, and they don't say, hey, I'm going to do a colonoscopy, I'm going to do a stool test. Should I, as an individual, say I haven't had a stool test for a long time, I haven't had a colonoscopy, I need to get that, or is
Yeah.
that supposed to be something standard?
Yeah. So firstly, the colonoscopy is what we call more invasive and is not done as frequently. Yeah, because it's more costly, etc. But certainly, by age 45, you want to have that stool test. Every 1 to 2 years, you want to have that. You should have your baseline colonoscopy if you can afford to, because it tends to be more expensive, and also because it's invasive at 45. And then once it's normal, and depending on your family history, the doctor will classify what we call as your risk. And then you might have to go back and have that colonoscopy every 5 years, every 10 years. So say, for example, a person of average risk who has no family members, who doesn't have any risk factors, who has their baseline colonoscopy and it's normal, they may be told to come back in 10 years. Yeah. But the FIT test, which is the fecal immunotherapy test, which is where you're looking at the blood analysis in the stool, especially if that's combined with the DNA test, you don't have to go to the hospital to get that. You don't have to, be put and sedated and all that. It's relatively cheap. That is something that you should be asking your doctor to do. If you have not done it and you're 45 or over 45, you need to request it.
Well, thank you so much, Dr. Greaves.
You're
We're out
welcome.
of time, really out of time. And so we want to express gratitude for the wealth of information you have shared. We have lots of questions, but we have next week. So we want to say to all of our viewers, we're going to be back with this discussion. We have a whole lot more to talk about. We're going to try to be a little more economic with our time next week. But we wish you God's blessings, and we encourage you to spread the word along and do like you did last week, because I noticed that even after the program, lots of folks went back and listened. And so we thank you and we wish you God's blessings. Take care of your health and see you next week at the same time. God bless.